Hello and welcome to the GRACE podcast series. My name is Denise Brock and I'm the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast, members of the GRACE Board of Directors, Dr. Jack West, Dr. Jared Weiss, and Dr. Ben Levy all sat down in their respective homes to have a candid discussion regarding COVID-19 and how it affects primarily cancer patients. In this 4-part series, the doctors discuss testing, risk, preventive measures, ongoing cancer treatment, and many other issues relating to a cancer diagnosis in the middle of the pandemic. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Hi folks, I'm Dr. Jack West. I am an Associate Clinical Professor in Medical Oncology at the City of Hope Cancer Center in the Los Angeles area, where I focus on thoracic oncology, and I'm also the founder and serve as president of GRACE, Global Resource for Advancing Cancer Education. I'm very happy to be here today with a couple of my colleagues who are also directors of GRACE, and I'll let them introduce themselves, starting with Dr. Jared Weiss here.
Hi, I'm Jared Weiss. I'm a clinician, clinical trialist, and section chief of thoracic oncology at UNC's Lineberger Comprehensive Cancer Center. It's a privilege as well to be a volunteer and vice president at GRACE.
And Ben Levy as well.
Hi, I'm Ben Levy. I'm associate professor at Johns Hopkins. I'm the clinical director for the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. I'm a thoracic oncologist like Jared and a trialist. Also serve on the board of GRACE. Very privileged to be a part of that and privileged to be here to talk about COVID.
So we are going to talk for a bit about some of the key questions that patients have been asking about coronavirus and COVID-19. And first, just a small distinction. Coronavirus is the name of the virus and the infection. COVID-19 is the actual syndrome of symptoms that accompany it. So you can have few or no symptoms from a coronavirus infection, in which case you wouldn't really have COVID-19, but you might hear those terms used somewhat interchangeably. Now, one question that I think is really on the minds of a lot of people is, should they get tested if they have cancer, whether they have symptoms or not? And this may really be a factor depending on where you are and what tools are available to you. Ben, what are your thoughts here?
Yeah, I wish we had the resources, obviously, to test everybody. I think we'd be in a very different place with those resources, and it may help steer strategy. But I think the current guidelines and our guidelines at Hopkins are not to test patients unless they have certain symptoms. And I think every institution has a different guidelines on when somebody becomes a person under investigation, or a PUI, or patient under investigation, a PUI. But for us, we certainly do have guidelines. Those guidelines are based on certain symptoms, or coming from certain regions, or even coming from a long-term facility with certain symptoms. We've come up with guidelines for testing only under those circumstances. And so a patient without any symptoms, who's doing well, who's not from a long-term facility, we generally don't offer testing, even in the setting, obviously, if they have lung cancer. We tend to try to follow the guidelines.
And how about the symptoms in particular that would trigger?
Yeah, so fortunately, I just went over these because a patient just called, but we have 7 symptoms now that you have to have 2 of the following. It's fevers, chills, shortness of breath, cough, sore throat, and then headache and diarrhea. So you have 2 of those 7 symptoms, then you are considered a PUI and should get testing as an outpatient unless you are sick and need to come to the hospital. And then the other, any unexplained loss of taste and smell in and of itself, you should be tested. And then if you have one of those symptoms that I just mentioned, and you've recently traveled from New York City, so we're close to New York City in the Northeast corridor, or from a long-term health facility, which was a little bit of a controversial recommendation by our hospital epidemiology infection control group, then also if you're from a long-term facility or from New York City, not that those two things have anything in common with one another, and have one of those symptoms, then also we consider those patients PUI and test them.
And I think one point that we should probably pull back and state is that it is currently mid-April, and we need to kind of timestamp this because our recommendations are likely to be somewhat geography, institution, and time specific. This has been a moving target. Different places become hotspots or not. And, as you allude to, some of this really depends on the concentration of cases and, unfortunately as well, access to good testing. I think a lot of us would prefer to have testing be available if we snap our fingers, but it's been much harder to do that. Jared, how about you? You're not in the same area, but so what are the policies there?
The themes are very similar to what Dr. Levy described, which is that we have criteria. They're more similar than different than what he described. But I believe in following them because we do have to triage the use of limited testing. But I do want to add the point that if we lived in a more ideal world, we would be testing asymptomatic people. We would be testing broadly. We'd be testing often. There would be favorable public health implications for that, favorable implications for monitoring of individual patients, but we don't live in an ideal world. We live in a world where our response has not been what many of us would like to see from one of the richest countries in the world. We do have limitations in testing, and in that environment, following these guidelines to make those tests count the most is appropriate.
Yeah, it's unfortunate. I think it's probably easier to get a PET CT than to get COVID-19 testing or coronavirus testing for a lot of our patients. So, and I don't have really anything to add except that in California, there's a reasonably significant burden or exposure of a bunch of patients, but it's been harder than we'd hope it to be at all of our institutions on the West Coast and in California to get the testing we'd like, and we have the limitations and the focus that you brought up. So great to get testing more liberally if you could, but that's not an easy task.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, Takeda, AstraZeneca, and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.